Hi everyone. This
Hi.
is you guys are. I hope you can hear us. You guys are the first people that we're testing this out with. So
Yay.
congratulations. Um, Welcome to our first sort of livey type of event, and hopefully it's on different social media channels. So let me see the chat. Um, so hi to Anza and to Azada. This is like calling out a register, isn't it? At school in alphabetical order. Um, welcome, guys. So my name is Tal. I'm one of the GPs, and this
I'm
is a
Sarah.
virtual background, and I've got white hair. So basically, with this white wall, it looks like I
Just
haven't got
blending.
any hair. So, anyway, I'm one of the GPs, so I'll be looking after you today with
Sarah.
the
I'm Sarah. I'm practice manager at HIOS, and I'll make sure Tao is on his best behaviour.
and welcome Nash and welcome KBS, welcome Sukna. So let's. You, what's going to happen, Sarah, in the next couple of days?
So, like Tao said, just bear with us because it's the first time we're doing this, live through social media. So we might have a few technical problems, but we'll try our best to get through them. But the plan is to kind of talk through different roles within the NHS, but not only that, talk about some of the things they do. So we've done some sort of webinars, some sort of clinical topics like diabetes, asthma. So we'll give you access to content around that. You will have access to something called Motimate. So you'll probably receive an email tomorrow or maybe later today, giving you access. So sometimes a lot of people miss things. They're like, oh, I missed the bit about clinical pharmacists. Tell me more. So through the app, you'll be able to access all the information about that specific role. You'll have access to the podcasts, the videos, and you can actually play games on there. And most importantly, you can access your certificates on there. So we know that's very important. So that will be coming through to you guys through the email that you registered on Eventbrite. So if you didn't register through Eventbrite, just contact us and we can get that set up for you. And yeah, we're just gonna kind of try and keep things fun. And if you've got any questions, I know you guys can't kind of come on here and or maybe we'll figure out a way might be able to. Um, but yeah, if you've got any questions, put them in the chat, and we'll be looking through that and answering some questions. So we'll talk through different roles today and tomorrow. We want you to get involved in some project work. So project work would be you guys creating a social media post. So we can give you access to maybe some videos that we're going to show you today, and you can go away and create that into a social media post. And we can look at your work on Thursday. So on day 3, we can go through work and again answer any questions and give you some feedback. I know that's a lot to take in, but don't worry, we'll be repeating that throughout.
And the
Let's
most
see.
important thing about this is just reflecting on what you have learnt. So just try to think about how you can how some of you guys are doing at school. Some of you are thinking about changing careers. So we're going to talk to you about doing either both clinical and non-clinical roles within the NHS. So there's lots of stuff out there. The NHS is a major employer in it's one of the biggest employers in the country, isn't it, Sarah? So,
Yeah.
and then it's not just doctors and nurses. It's like a whole load of other people. 1.8 million people. So most people know somebody who works in the NHS uh, or works in the NHS. So we're going to show you some of the things some of the roles that you might be interested in working on. And then if you write your reflections, then that will be a good way of you being able to make job applications or applications to university, whichever area that you're interested in working in. And actually, we've got lots of other people who are interested in working with us, including hospitals and universities and schools and loads of other people. So yeah, so just keep an eye on our social media channels, and we'll keep updating you. There's also, this is a virtual work experience piece, but Sarah, do you want to talk people through the face-to-face one as well?
Yeah, so we actually did a face-to-face work experience. We did two actually a few weeks back, to see, because we know how much you guys want to come into the practice and do a face-to-face work experience. So we thought we can't really do the one, one person coming in. We wanted to do it as a group. So we tested it initially with 30 people coming into the practice. And we had like different stations, so you would go around to different rooms and learn about the different roles in each room and learn about different clinical topics. So, and actually get your hands in and use the equipment that we had. So, for example, our clinical pharmacist was talking about blood pressures, and we had blood pressures laid out in the room where you can actually go check each other's blood pressure. And same thing with our nurse practitioner, he was talking about BMI. Would go in, check their height, weight, figure out what their BMI is. So really kind of hands-on, and you would only get about 5 minutes in each room. So it was very quick. And yeah, we had really good feedback. I don't know if anyone, let us know if you attended that. We might have some people who might have attended that face-to-face work experience. And then we tried it again with 100 people. Was it, or was it?
Yeah.
I'm forgetting the numbers, but yeah, around 70-ish. So yeah, it worked really good. So we're planning to do a lot more of those. So just watch this space.
Big fat hi to Malika, Smitri, LB. I wonder what LB stands for. Can you guess, Sarah?
LB.
Oh, LB says hello. Mathuli, Navneet, Maza, Intisar, Anna, KBS. I wonder what KBS stands for. All these cool names.
Oh, KBS attended. How did you find it? Tell us how you found it. And Maza, yes, you do get your certificate.
And a big shout out to Lee as well, who just messaged me here. Lee, I can tell you, is a legend. We should have him on the panel, actually, shouldn't we? So we've got loads of really cool people who are really keen to help out on this program. So yeah, let's get started, shall we? So
should we start off with talking about our roles?
Yeah.
And then we can kind of jump into maybe talking about SAN.
Yeah.
So we're going to keep this. Yeah, guys, keep your comments coming in. If you have any questions about our roles, we'll answer them. And we usually start off actually by asking people what they had for breakfast.
Yeah.
Maybe we should start with that.
Can I kick off? All right, we got the KBS. Kajida B side. Very good. I was going to guess that actually, did you? But you beat me to it. So all I've had for breakfast is I had to break it to you guys, but Dr. Mead needs to lose a couple of pounds. Is looking bit. He's put on a few during COVID. COVID hit me hard. So I'm trying to lose a bit of weight. So I'm not entirely sure this is particularly healthy. And then interestingly, we've got lots of people who, like dietitians and stuff, to tell you how you can become healthier and fitter and all the rest of it. And the healthier and fitter you are physically and mentally, the better you're likely to perform at work and to get in your exams and all the rest of it. So basically, I'm not entirely sure, but anyway, coffee. I've had 2 cups of coffee and a few nuts.
Is it black coffee?
The first coffee was, this one's got a tiny little dash of milk in there.
Any sugar?
No.
Oh, okay.
I look like I take sugar, but I don't.
No comment.
I look like I've got diabetes, but I haven't, but it's only a matter of time. What did you have for breakfast?
Don't worry. I had black coffee and I had a pancake. So
what?
I know. I mean, It was okay. I didn't put anything on it. Like I didn't put. Usually I'll put like Nutella and stuff on it, but no, none of that. Tell us what you guys had.
Oh, that's all right then.
Let us know if it's healthy.
How many
We should get our
pancakes were there? There was
dietitian.
like hundreds.
No. I had two small ones, very small.
Yeah, whatever. What did everybody else have?
No one's everyone's half asleep. Are you guys? It's half term. Are you guys still in bed? Are you
Yeah,
joining in bed?
yeah, you should. I think people who are aged between 16 and 18 don't get out of bed until 2 o'clock in the afternoon, do they?
You think so, guys?
Yeah.
Let us know. Oh,
Oh,
someone had eggs. Tuna sandwich. That's Tal's favourite.
oh my God! You had tuna sandwich and for breakfast. Seriously, that is my perfect lunch. Mazza's still in
Yeah.
bed, right? Yeah.
Yeah.
I'm glad you're
Don't
taking
blame
it
me.
seriously. Cocoa Pops.
Smritty had Cocoa Pops, cornflakes. Oh, I rushed to join the live.
Oh, that's why I like
Nice.
fully committed.
Yeah.
Fully committed. Right then, so we're going to talk to you about different roles in primary care. So we're going to talk a little bit about GPs and managers, and then we'll talk about other roles like clinical pharmacists and physios and other bits and pieces. So we've put together some really cool content, and we'll get to show you around the place, and you get to just get a little insight into their lives, and I'm happy to answer any questions. So Hannah wins the prize, by the way, for porridge and blueberries.
Wow.
Blueberries porridge is like amazing, makes you like not hungry for a couple of days at a time. And blueberries are a superfood. So if we have prizes, then Hannah gets it. And
I mean, let's see what you guys have tomorrow when you join tomorrow.
Yeah. Find out tomorrow. If everyone's going to say porridge and blueberries, aren't they? Right. So general practice. Basically, to be a GP, things. I'm obviously a very old man, and when my day, you had to do A levels and stuff, and A levels and GCSEs, A levels, and then applying to medicine and own Kings. In the olden days, the entrance for Kings was, I think it was 3 Bs or something, or A and 2 Bs. It's obviously changed a lot now. But yeah, I think it's like important to think about like what you want to do for your career, whether or not that is the right thing to do. Sometimes like exams and stuff don't quite work out, and my predicted grades were D and 2 Es. So I
There's
thought
hope.
there's hope for everyone, and I've failed loads and loads of exams over the years, so it's all good. I think it's just like you kind of have to believe in yourself. I sound like a bit like Ronaldo or something, but yeah, I am the Ronaldo. But you got to believe in yourself, right? Because a lot of times people say, "Oh, you can't do this and you can't do that," and well, you can actually. And exams are one bit, but actually there's lots of other things that you can do as well. And it's really, really competitive at the moment. So, like, I know everyone needs like 5 As, and they need to be experts at non-academic stuff as well. But yeah, I think it's I think you just got to when it came to exams, you just have to really focus and just try to have as much practice as possible, really. Some people work differently, so some people work better in groups and stuff, but some people work better alone. I tend to work better by myself when it came to studying. Yeah, KBS. It was Bs for medicine. Those happy days. And anyway, I got A and 2 Bs, and I got in through King's through clearing, and then after, and then like once you're in medical school, it's kind of it's okay. It's like you get to meet different people, and King's is a really good university actually, because it's not just doctors. Like Imperial is a massive university with like 400 medical students in there, and that's too many people, I think. So at least at King's, still got friends who have a non-medical background, and you can meet people who are not medics, which I think is quite important. And then I want to become a gastroenterologist. Sorry, did you know that?
No, I was going to say to you, what did you always know you wanted to be a doctor? Is that
No,
what you kind of know? What did you want to be?
I don't know. I think some people have this like burning desire to be a doctor or something, but I didn't really think about work.
So why didn't what made you get into medicine? Well, why did you
Well,
want
my
to?
brother was, and I thought well, if he can do it, then and it's a nice profession, right? Because you're kind of it's a nice thing to do, isn't it? You're kind of helping out, and it's nice and stuff. And oh yeah, my mum obviously wanted me to be a doctor, so a
Of
lot of
course.
pressure there as well. But it wasn't like it's yeah. So, but I think
So you wanted to be a gastroenterologist.
yes,
What happened?
this idea I want to get across actually is failure. So failure is okay, I think. So I failed my exams to become after you finish medicine, you have to do postgraduate exams. So there's part one and part two, and then I didn't quite get through those exams, and then I decided to be a GP, and then oh yeah, thanks KBS for the misconception of GPs not being real doctors. So that was actually in those days that was a GPs not being real doctors was something that you know general practice was basically a fallback position. I think now it's
Really?
actually So if you couldn't get into being everyone wants to be a surgeon, right? I bet a lot of you guys think that
Yeah. Tell us if you want to be a surgeon.
that's
Let
what you
us know
want
in
to
the
be
chat.
when you grow up. But actually, I think general practice, like we had this professor of surgery, Professor Howard at King's, who did really super specialized surgery around biliary atresia, which is like basically a congenital abnormality where there's something with the bile duct that's a bit sort of not working. Then you have to have surgery when you're a small child, when you're just born, really. And his outpatients were like people all around the world, and actually, if you think about it, he's a very clever man and all the rest of it, and he's world renowned. But end of the day, he's doing one super specialized area of surgery, and that's all he does. I don't know. Maybe you could argue that's a bit kind of dull. Maybe I'm just saying, maybe. But in general practice, you see lots of things. I think you see people grow up over the years, and you know, So we've worked in the same place for a long time, so you watch people grow up, and
Yeah.
and their families, and you kind
Mm.
of see them go through. Quite often people come to you when they're in a pickle and stuff, or if they're like if it's stressed, or work problems, or whatever. Not many people make an appointment say just say everything's fine,
Mm.
but I think it's really nice. They don't get that in hospitals, I think, and also because it's like a wide area that you cover, you can take an interest in different areas that appeal to you, and it's flexible as well. So I think now there are more people that are
That's
actually
true.
going into general practice, and um, if you look around, there are um, you know um, primary care in the UK is probably the best in the world, probably. Perhaps there's a few other places that do it well. But I completely agree with your comment earlier about GPs around the world not necessarily being perceived as equals to, say, a professor of surgery. But for me personally, I think it's a really rewarding career, and I think you do make a difference. I think we're making a difference with this stuff here today. And yeah, so one of the things we're going to try to do, so there's obviously the way that things were worked in when I was little is very different to how it is now. But we're trying to get some medical students in. So we've got one medical student already who's who's done some videos and stuff about how to get into university. And we've got others who want to help out as well. So we might be able to do some mentoring and stuff with some of our colleagues from Brunel University. So yeah, that's it. There are a few questions over there. We can do that question thing, couldn't we, Sarah, a bit later on? Should we do this now and then go back to the question thing?
Let's just answer a few questions.
I'll try to do overlays.
Okay. Oh, it's only new comments that will display. Okay.
So let me. Oh, I can show them though. So there's Hannah's comment there.
Orange.
So KBS's comment saying B's for medicine. Yeah, too right. So I think we've answered this one. So this is an interesting one. How about foreign doctors who live in the UK and struggle to get back into work? I completely agree with you, Rob. That is a massive issue. And I think it is harsh when, on the one hand, we're saying, oh, there's a recruitment problem. And on the other hand, the loops that doctors have to go through, foreign doctors have to go through, is really quite high. PLAB is very difficult. What we could do, Sarah, is bring on some people who actually are foreign doctors and maybe share their experience. We could do that. I'll make a note of that.
Yeah.
Yeah. So, KBS surgery is not my go-to. Good girl, KBS. Come and be a GP. But Mazza wants to be a surgeon, neurosurgeon, very specialised. Keep your mind open though. There's lots of other things that you can do. But yeah, it's good that you've got some focus, and then when you're doing your work experience stuff, don't be too fixed on that. But do try to look for other options. Let's see. I want to be a cardiologist, but don't want to do the surgery side. Well, funny you should say that about cardiologists, because we've got a really cool cardiology doctor, haven't we, Sarah? Do you want to share Emmanuel?
Yes. I can't remember what. Emmanuel hasn't come on our sessions for a while. We need to invite him back in.
We'll bring him back.
And actually, yeah, we'll bring him back.
There is this thing, interventional cardiology, where you can be a cardiologist where you use tablets and stuff, but actually you can do a lot more tech stuff with pacemakers and opening up vessels, and so there's a lot of overlap between those two. Cardiothoracic surgeon, maybe you can come and see me, or maybe I can come and see you, because I probably need some help soon. Your radiologist in the UK, if any support for training and same time getting equivalence, we've done, appreciate it. I'm working in May English. Radiologists, so this is Royalty Roadblocks, who's mentioned the difficulty in getting into the UK for training. So I think it's worth us bringing in somebody who's got expertise in the way to get into the UK So we'll bring in
I
the
think it would be,
experts to help you with that.
yeah,
So
yeah,
message
definitely.
us separately, and then we'll hook you up with somebody. Oh, this is relevant.
Yes. I'm really excited to see how the degree apprenticeships go, especially for the GP degree apprenticeship. I'm quite excited to see what happens. So we don't know how it all works. I think the first round is going to be, is it this year?
Yeah,
I think in September. So it should be interesting.
I think it's very exciting actually. So Malakia, the thing is that there aren't many. Although it's being that degree apprenticeship stuff is showing up as, and everyone's talking about it. There really aren't many places for that actually. So you think, oh, okay. On the one hand, I have to pay what 10 grand a year for 5 years and all the student loans and all that stuff. On the other hand, I don't pay anything and I get paid. Like it's a no-brainer, isn't it? So, but I think there's a difference between what they, the number of places and the amount of noise that there is around that. So I think it's really difficult to get that. Okay, this is an interesting one, Kerry. Do you think that even if you don't get the grades you want, medical school via alternative routes is still possible? It is, isn't it, Sarah?
Yeah,
Potentially.
I,
I
I
mean,
think so.
one thing I would say to you actually is, like, first of all, medicine is more than just more than just let's have a look. More than just somebody's written a very Nash has written the world's longest comment. So I'll just. So yeah, so medicine is more than just you have to really think, is that what you really want? Is that what you really want to do? And you think about the end, like, what is it that you actually want to do? If you want to make a difference and you want to help people, then actually you can do that in lots of different ways. But ultimately, if you want to do medicine, whatever it takes, then you can. You can go abroad. You can do. There are private medical schools that you can access, which are difficult as well, but they are expensive. The key thing is really what you want to do, and hopefully being on this program, doing a bit of work experience, spending some time with other clinicians might make you think, oh, whether or not that is the right thing to do. So Intasar says, I'm a phlebotomist healthcare assistant. I could get a job until now. Syra?
Do you mean you couldn't?
You can't.
We'll give you a job.
You can have a job.
You can have a job. Yeah, it's honestly, with healthcare assistant, we actually want to, Maria, our healthcare assistant, we've got some kind of content around her role. She'll be explaining about how she went on, to, be a phlebotomist and what sort of things she can do. We've got actually a webinar around diabetes, so she sees a lot of our diabetic patients for reviews, and she's going to be giving us actually, one of the things we're talking about was top tips on like diet and exercise and things, so she's an expert in our practice. But yeah, phlebotomy roles, I mean, have a look. Generally NHS jobs website is really good. Like if you're looking for jobs, just type it in there if you can find something, or contacting practices. But I mean, I know practices in our area always looking for healthcare assistants and phlebotomists, so definitely contact us.
So let's have a look. Can you take more than one specialty? Kay says. Someone chooses emergency medicine. Can they also specialize like GP? And the answer to that, Sarah, is
I don't know. I think so.
definitely. So,
Someone chose medicine.
so like you can definitely be
Oh, okay, later on, yeah.
a GP. Yeah, so you can be a GP with a special interest in whatever. So
Okay.
we've got Faisal, who is
Yeah.
one of our GPs who's doing musculoskeletal medicine, and Sonny, who's done some videos as well, isn't it? So he works at the urgent care centre in West Middlesex Hospital. So that's the thing. Like you can definitely that's the thing about general practice, is that you can specialize in lots of different areas if that's of interest to you. There's quite a lot of questions, aren't there? So I wonder if we should move on to you, because this is let's answer this quickly.
Okay.
So I'm starting MSW band 2 soon. I want to progress to midwife through degree apprenticeship. So that is another good question around apprenticeship. So the nursing apprenticeships are coming through as well, and they are starting to. So I think you just have to apply as you would any other way, but the thing is that you need to demonstrate that you're the person for that apprenticeship. And I think coming to this sort of program, doing some reflections, increases your chance of getting onto those apprenticeships. Heard salaries in the NHS are very low. No, I don't think that's true. I think we get paid very well for what we do. I think we're doing it full because we want to do it anyway. Junior doctor earnings are low, yeah, maybe, but actually earnings do get better later on. And the £11 an hour, I'm not quite sure how they calculated it. I think if you're definitely not doing medicine for the money, but you're not going to be, you're going to be, if you have a reasonable income, as a doctor. So
there's always demand, isn't there?
There's always locum work and stuff. So what different sectors of pharmacy would be considered as part of clinical medicine? So another really good question, and Simriti. So we've got Sam who's got a video, so we'll share some stuff on that. So in summary, there are loads and loads of jobs. I'm really glad that it's not just doctors, and that you've brought in, healthcare assistants and pharmacies and other nursing midwives, other roles. I think that is so important it's loads and loads of other jobs other than doctors. And actually, within medicine, there are millions of different opportunities as well. But one of the other things we want to kind of get across actually is that, like, almost half the jobs, which is why there's two of us here, half the jobs are not clinical at all. So all the ones there listed are clinical jobs, but actually there's lots of others, aren't there, Sarah? So do you want to talk through the non-clinical roles?
So many. I think I don't know if you just mentioned that like 50% of the roles are non-clinical. So I think a lot of the time when you think of working in the NHS, you're thinking, doctors, nurses, but actually, a lot of it is around admin roles. So you've got, for example, receptionists, administrators, you've got managers, you've got care navigators, you've got like finance departments, you've got social media teams as well, comms teams. So you've got a whole range of non-clinical roles. For me specifically, so I'm a practice manager. Everyone's like, what is a practice manager? What do they do? I don't know. Like, I think it's just the overall kind of responsibility of running a GP practice, kind of looking at, managing clinicians, the admin staff, looking at different projects, but just making sure everything kind of runs smoothly, to make sure that we're, delivering, good patient care. This includes like things like HR. So there's boring things, the health and safety things, the financial kind of things. But we do get to work on really cool projects like this one, providing, work experience for you guys. So, organizing that. Getting into, practice management, there are some qualifications and things you can do. So for me personally, what I did is I did an apprenticeship. So whenever anyone talks about apprenticeships, I'm like, yes, apprenticeships are the way to go. So I did an business administrative apprenticeship. This was like, I don't know, over 10 years ago in the same practice. And then I just continued on. So they hired me and I worked as a receptionist, and then kind of went on to become reception manager and practice manager. So I think there's lots of opportunities within the NHS. I don't know if you've got any questions, guys. Ask. I don't know. I don't know if you want to ask anything, Tara. I don't know. It's weird talking about your own role. I don't know what to say.
I'm just playing around with this.
Oh.
I don't know. I think, like, say for example, somebody's interested in human resources or something. There's loads of jobs, aren't there? Or technology, or
so many. Like you've got hospitals, you've got GP practices, you've got something called PCN, so primary care network. So you kind of group up a network of GP practices working together. But even within that role, you have a manager. You have different roles within that group. So I think, definitely that there's so much out there. Sometimes a bit hard, like how you find, like I think Insa was saying, where do you find those roles? What do you kind of, when you're thinking of, doing social media work, you don't necessarily think of doing it within the NHS. But yeah, I guess looking on NHS websites, I think we're hoping to get kind of different roles up and give you guys the opportunity to apply for different roles. So we're going to be looking into that. Thanks, Sarah. My last few.
Oh, let me show that comment.
Oh, thanks.
So I think training is concerned. Do you think there's a role for people who are just interested in, say, project management, or what about managing buildings or transport or any of those sort of things? Is there a role for that in the NHS?
Definitely, there's huge, there's like a whole, like you said, like departments on just specifically those areas. So I think definitely look into it. And I know you don't really think of it, it doesn't come to mind when you're thinking of NHS and thinking of estates and HR and things. But yeah, huge team. You definitely need people within those roles. We need that for the NHS to run. So definitely look into those.
Just to give you an example, actually, because I think Chelsea and Westminster have 6,000 staff, and like most of them, well, probably about half of them are not clinicians. And then you've got Imperial, which has got even more staff, 15,000 something. So huge numbers of staff, and none of it works without not just managers, but every little stage of that whole process, from data analytics to technology to research. That's non-clinical role as well. So yeah, lots of things. So, and the best place to look for jobs, Sarah, would be NHS Jobs.
NHS, have a look on, new platforms like LinkedIn and stuff as well is quite good. Have a look around, but I think most people do put vacancies up on NHS Jobs, ones that I know of. Sometimes just contacting the practices as well. And if you're not sure, like sometimes I think a lot of people are like, I don't have experience working within the NHS, I don't know how to just make that first step. like Tal was saying, like things like this is really good, like going to someone and, you know, applying for a position and it being in your CV that you attended this work experience program and this is what you learned. It's always about reflections and what you got from it, and kind of a better understanding of how the NHS works. And actually volunteering, I know someone put it in the chat that, you know, volunteering as well is huge. It helps loads. You know, we had a volunteering program that we set up, and actually a lot of people went on to get jobs within the NHS following on from that. So definitely look into that.
Cool. All right then. So should we go on to show one of our little video things?
Should we start with Sam's? I can only upload one video at a time on here, but let's see if this works. Oh, Tal's disappeared.
Do you want me to play it?
Do
you want to do a little intro, and then I'll play the video when you're ready.
So Sam is our clinical pharmacist. He's going to explain what that is and what his role is. So I think this video is, I think, just talking about his role. So go for it, Tal.
Hi, my name is Samir. I'm a clinical pharmacist working in a GP practice. I have a master's degree in pharmacy and also independent prescribing. I specialize in all medicines and safely prescribing these medicines for long-term conditions for patients, specifically those patients with high blood pressure, diabetes, and asthma.
So, give me an example of somebody that you saw recently.
So I recently saw a patient who had just come into the country. He was recently diagnosed with type 2 diabetes in India. He was still experiencing symptoms of diabetes. He was feeling excessively thirsty, excessively hungry, waking up in the middle of the night, still going to the toilet. And I just called him in, spoke to him, just got a real sense of whether or not he'd been taking his medication accordingly from India. Found out that he wasn't. And just what next steps would be sort of possible to get the best out of treatment and just to help him in his day-to-day activities as well.
What's the best part of your job?
Probably the patient interaction and just seeing how you can help patients from the start of their sort of treatment all the way up until them maintaining their treatment.
And what's the difference between a community pharmacist and a clinical pharmacist?
So I think a clinical pharmacist is more involved in the sort of diagnosis and management of that patient and their medicines. Community pharmacy is really good in a sense that they sort of keep on top of the medication in terms of making sure that doses and everything is appropriate. But clinical pharmacist in a GP setting is where you're doing the nitty-gritty work.
So that's clinical pharmacist. I think it's really it's interesting actually about the new roles that are happening in general practice. So those sorts of clinical pharmacists are a relatively new thing. So you have to basically do a degree in pharmacy first, which is normally a 4-year degree, and then you can go on to have a variety of different other roles. So it can be in hospital, it can be community, it could be in pharmaceutical companies. So those are the broad areas, but some of them are now starting to work within general practice as well. So general practice is something that clinical pharmacists and community pharmacists are pharmacies. We work very closely together, and the clinical pharmacists are the link between the GP practice and the community pharmacists.
So what's
really well. Doesn't it, Syra?
You could tell we're using this for the first time. Yes, and I think Sam is going to talk a little bit about what that CP. I still don't know what it stands for. Is it that CPPE?
He struggled to see what it stands for. Yeah. That's an 18-month course, the CPPE course, and then what it does, pharmacists obviously are absolute experts in managing medication and stuff, but it just helps them with the examination and stuff as well. Often they're independent prescribers at the end of it, so they can sign their own prescriptions. They're a really valuable member of the team, and that role is increasingly expanding. Have you got?
It's so helpful because Sam specifically, he in our practice, he works in reception. So it all is an open plan office, and actually he's, you get someone with a query about medicine, and somebody comes in and says, oh, can you just confirm this dose or whatever, and he's just there and he answers, and it's just amazing. Otherwise that kind of query would usually go round and round in circles, and we have to ask that person, we have to send them a message, and that person, and it's just so helpful him being there, and something that he just knows at the top of his head and he can just answer. Or like even during triage we'd be like, oh, can you just confirm this or that, and yeah, honestly, he's amazing.
And sorry, we've got some more videos of Sam. Do you want to share them?
Yeah.
CPPE stands for the Center of Pharmacy Postgraduation Education. So it's just basically a collective hub where you do all of your sort of extra learning to help develop you as a pharmacist. Maybe because I know a little bit more about the effects of medicines on the actual body itself, I have first-hand experience about how patients feel after taking their medicines, and I'm basically a bit more accessible in the community as well and getting feedback.
So what's the difference between structured medication review and a medication review that your GP might do?
So a typical sort of medication review that your GP might do will just be focused on, let's say, one medicine, for example. A structured medication review looks at all of your medicines. It also looks at sort of your social life in terms of whether or not you exercise, your sort of diet, your consumption of alcohol, or whether you smoke. So it takes into account your whole persona and your whole sort of day-to-day life as such, not just including your medicines.
And how long does that take?
Structured medication reviews can take anywhere between about 20 to 30 minutes if done properly.
Right. I thought the video was a bit longer, but clearly
Every time
not.
those videos stop, we always catches us off guard.
I know.
You'll have to bear with us, guys, because this is like the first time we're doing this. Have we got any more Sam videos, Sarah?
Yes, actually, recently he did something around measles, didn't he?
Yeah.
He did. So him and Sunny, our advanced nurse practitioner, did a bit of it. Actually, you know what? Before I go into that, I'll show you a day in his life, right? Because he's talked a little bit about it, but you can kind of see what he does. I think this is a cool video, so have a look at this.
Day in the life of a clinical pharmacist in a GP practice. He makes himself available on Teams to ask or answer any questions from staff. Telephone consultations and tasks include speaking to patients who are newly registered, who need their medications to be updated to the records, or making sure that medication changes made by the hospital are up to date. He has a quick coffee break and then gets ready for the afternoon clinic, which includes seeing patients face-to-face for asthma, diabetes, blood pressure and medication reviews, making sure that they are compliant with their medications.
That's Sam. I can't find his measles video, so give me a second.
So, yeah, if you've got any questions about clinical pharmacists, then just pop it in the chat. So we're going to do this. I'll answer some of the questions here whilst you're getting that ready. Then,
Yeah.
Sorry. So, question from Good Maths. Can a doctor in the UK work in the US? How difficult would that changeover be? Technically, doctors can work anywhere in the world. You have to apply for registration with their local sort of authority, the regulatory body for different countries. There's a huge drive for doctors to go to Australia, Canada. Used to be Middle East a bit. That's less so nowadays, I think. But certainly Canada's the big one that's coming through at the moment. So you do have to register with their local body. You have to do some exams and stuff. In the US, those exams are called the US LME exams. it's best to get them done like when you're doing your final exams, like, because it's lots of biochemistry and amino acids and stuff that anatomy, things that you'll have forgotten when you're my age. So yeah, so the answer, can UK doctors work in the US? The answer is yes. And how difficult the change would be, I think the US is quite difficult. They got, those exams are really quite tough, and I think they don't make it easy for UK doctors to go over, but there are other places like Canada and other stuff as well.
We have some doctors who kind of work abroad and come here sometimes, do some shifts with us. So
yeah, and actually that's interesting concept. So we've got doctors who have trained abroad and then qualify here. You know, like there was somebody from South Africa and some other places as well. So there's so that you can graduate from one country and then train in another country. So it's just about where you can, and you could go and work for the World Health Organization. You don't have to do clinical roles either. So this is slightly interesting one. My job applications get rejected. I don't have required work experience, even though I have my university degree. How do you gain work experience as employers with an opportunity? So Jennifer, that is exactly why we're doing this program. It's sorry, do you want to explain? Because it is such
it's so difficult. You're right. Was it Jennifer who put that in? That the whole point. You go to interviews and people tell you, oh, you need experience, but where do you get that experience if they're not going to give you that opportunity? So that's exactly why we're doing this. I mean, we have a video about why we're doing this, but I'm not going to show you because I think it's either me or Tao talking about it. But yeah, we get requests for this all the time, like, give us experience, and we really want to do it, but people don't, we just can't. So that's why we're kind of really spending time putting these kind of programs together to offer this to you guys, because you can then go in and say, right, this is, even though you're not, I know sometimes people want placements for like a week, 2 weeks, but when we've done work experience previously, people would just sit in the corner and just kind of open letters, for example, and that's not what we want. We don't want you to just sit in the practice and just look at us. We want you to be hands-on, get involved, and we've always gone about like volunteering opportunities, like actually go and do something and really learn about how it is hands-on. So yeah, that's the reason why we've put this together, because we want you to get into work, get jobs. Not just something to put down and have on your CVs, but kind of and like Tal said again, it is really about reflecting on what you learn from it, because when you go to those interviews, and actually you need to be able to say, yes, I attended this, but what did you get out of it? What did you learn?
Okay, and then Sam's video, is that ready or not?
Measles, yeah.
Yeah, okay. So do you want to give a little intro, Sarah?
Oh, sorry. So Sam and our advanced nurse practitioner, they were working, measles at the moment, there's an outbreak of measles, so something really important. And we just had, we use social media quite a bit, and we looked at the sort of comments that were coming through, so questions that people were asking. So we went through the most common ones, and actually Sam, our clinical pharmacist, and Sunny were kind of going through and kind of answering some of those questions. So here you go, you can learn a bit about measles.
Sunny.
Hi.
Measles.
Yeah.
It's going about now.
It is.
I had a few questions. I wondered if you could answer them for me.
Yeah, sure.
Can you get measles if you're vaccinated?
So the chances of getting, first of all, the vaccination is really important. It reduces your chances quite significantly. Yes, there is a rare chance that you could get measles, but the symptoms are less likely to be catastrophic. So that's what we worry about with measles. It can lead to severe complications, particularly things like meningitis and deafness, which are obviously very bad things.
Yeah.
So 2 single doses of your MMR can reduce that significantly. And if you do end up getting measles, which is very rare, your symptoms are going to be a lot more manageable.
Good. What does like measles look like exactly?
So usually starts off with a small kind of flat rash, redness on the face. Sometimes you can get runny eyes, conjunctivitis, a high temperature. You can get some spots inside the mouth as well. And then that rash usually spreads across the whole body.
Is it itchy? Because I feel like some patients or mothers will come up to us and say that it looks similar to, let's say, chickenpox. But is it itchy at all?
No, so chickenpox, very kind of characteristic of like blister-filled bubbles all over the body. You can kind of, when you see a chickenpox, you can kind of tell it's a chickenpox.
Yeah.
They are very itchy. Measles not necessarily always itchy, though later on, once the measles develop, it can get a bit itchy, which we can then control with kind of antihistamines.
You pretty much see chickenpox mostly starting on around the abdomen area, and it's really, really itchy. Is it contagious, measles?
Yeah, so it's one of the higher contagious kind of diseases out there.
Compared to COVID?
Yeah, so it's 15 times more likely
Really?
to spread. So it's a big problem with children at school, particularly those that are unvaccinated. And then it has a high risk for people that are pregnant, for example, people that are vulnerable to other diseases, so immunocompromised patients. So you're 15 times more likely to get measles through kind of respiratory-borne infection, droplets, so when you sneeze or cough.
Wow.
So yeah.
Okay. So I know it's very important we say that kids need to have, or children need to have their vaccinations. Their first one at like 1 year and then their second one at about 3 years.
Yeah, correct.
Can adults actually get measles?
So adults can get measles. If adults get measles, it's a little bit more worrying than children, particularly if they're not vaccinated. So adults go on to get complications such as what we call encephalitis, which is a swelling in the brain. So that's why it's really important to get those vaccinations as a child.
Okay. And can you get measles twice by any chance?
Very, very unlikely. It can happen, like with anything, but very unlikely. And if you're going to get it the second time, it's going to be a lot milder.
Are you finding that people are missing their MMR vaccines quite often? And what's the situation that you're seeing right now?
Yeah, so we're seeing quite a lot of people that are not taking their routine vaccines, and it might be around kind of being busy. We all live in London, we're quite busy with our work, but it's really important getting those vaccines. It doesn't take long. We've got nursing cover, and lots of your GP practices around London will have nursing cover, later appointments, even weekends, and we can try and fit you in there. If you've got any questions, so if the patient's got any questions, we invite them to come in, and we can have the discussion around the vaccines. And our staff, so the nursing team that give the vaccine, are so good and gentle at giving them that's the kind of things that they do day to day. So they'll take that into consideration, especially if you're worried about needles, etc. And they'll make it as comfortable as possible for your child as well. But it's really important if you feel that you don't have you're not up to date with your vaccines, for example, or if you've got any questions, definitely contact us, and then we can work around your needs.
Perfect. Thank you.
Yeah, no worries.
That's all you need to.
We're going to test you now on measles, so.
Didn't tell me there are any tests here, Sarah. Yeah, if you've got any questions, then just. Or should we do some of those questions?
Yeah, let's do some questions. There were, I don't know, which one did we get up to? Okay.
Do clinical pharmacists get paid more than normal pharmacists? I think that's a difficult question to answer. It depends on what you do as a clinical pharmacist or normal pharmacist. We've got on our website, we've got a little blog, and that's got pay. Yeah, then that's got kind of stuff there. So hopefully it will give you some idea, but the answer to that is it depends really. So to become a pharmacist clinical or normal, you need to go to university. Option of apprenticeships or internships. Now that is a good question.
There are. There are some. I know the pharmacy technician one, but again, like Tal was saying, like there are apprenticeships available, but it's about the provider who provides those apprenticeships. There's not that many people who provide it, so maybe I think in a few years you'll get a lot more people providing it. But at the moment, there are some. I can have a quick look. Yeah, pharmacy technician, pharmacy services assistant, and there is clinical pharmacology scientist, level 7. So there are, but again, I don't know who.
Well, there you go. Sorry, we got the answer here, right underneath.
Oh no, yeah, I put that in the.
You've done that.
Yeah, that's what you need to do if you're going down the university route.
Sorry, I've put all the answers down.
Sorry, yeah, that's the same one. Don't know why it came up twice. How many
GCSEs is variable, Manaya. It depends.
It's 5.
Yeah.
Yeah.
But there's a difference between the minimum number and the number that you actually need to get onto the program. So just have a little many as possible, isn't it? Really depends on where you're applying, what you want to do, which university it is, what role you want to do, that sort of stuff. So, but we will provide you with specific. I mean, I'm not promising anything, but we might be able to arrange a trip for you to visit, some of you guys to visit the university and stuff. So, to see the different, the medical school, the pharmacist, the physician associate program that they have, and they would be much better to answer questions around what it takes to get in. Manaya, I think for most of them it's around 5. I guess, Manaya, you're studying for your GCSEs. Do as many as you can and get higher grades as you can, and you should be fine. What next, Sarah?
Should we do healthcare assistant? I know we were talking a little bit about phlebotomy and things, so I'll show a video of Maria, who's our healthcare assistant. So kind of day in her life, what she usually does on a day-to-day basis, and then we can go into maybe some of the things she does within her clinical role. So here is Maria.
Day in the life of a healthcare assistant in a GP practice. She likes to come in extra early and plan her day. She takes incoming calls from patients who are requesting their repeat prescriptions. She also checks if they're due for any medication reviews or long-term condition reviews. She gets ready for her face-to-face clinic. As you can see, she's very organised. She is trained on using different equipment. Some of the patients she sees are for blood pressure checks, blood tests, diabetic reviews, doing ECGs. She also gives advice on stop smoking and general advice on living a healthy lifestyle. She makes sure that her room is kept clean between each patient, and then she completes any admin tasks like processing repeat prescriptions that are sent to us online, sending referrals, coding hospital letters, printing sample forms. She also helps in COVID clinics when needed. She ends the day by spending time in her beautiful garden.
She's on holiday at the moment.
Maria's beautiful garden. There it is.
Other things that Maria sees quite a lot of diabetic patients. Now, diabetes, diabetes is a bit of a problem, isn't it?
It's a huge problem.
Is anyone more at risk of, apart from you, is anyone more at risk of developing diabetes? Is a certain, or actually you guys can tell us in the chat. Who do you think
would like to get diabetes?
Is more at risk of developing diabetes? Maybe certain ethnicities, maybe. Let us know what you think when I get the next video up.
While we're waiting for those answers to flood through,
I was hoping that people would put it in the chat.
I know, but I can't see anything.
Yes. Asians, so South
correct.
Asians definitely. There was. Do you remember how many percent? What? Yeah. I don't remember.
Well, you asked me.
Actually, I think Maria, our healthcare assistant, you
They
just saw in
cover
that
it in
video,
this. Okay.
and Nick, who's a GP, are going to talk about. Oh, he disappeared.
Ten,
9,
8,
7,
6,
5,
4,
3,
2.
1.
Graphics. Sorry, you got the graphics.
I've got random graphics if you want to see this.
Oh my goodness, I think it's time to start.
Okay, hi everybody, my name is Dr. Nick Sharma.
And I'm Maria, HCA, and I give life health advice for our patients.
Welcome to our live webinar. Today what we're going to be doing is talking about type 2 diabetes. So we're going to be talking a little bit about diabetes, what diabetes is, just a brief overview today. And at the end you can ask us any questions that you may have. So should we start off, Maria, would you like to explain? I know you see this sort of day in, day out, and you're amazing at this. So just in a nutshell, assume that I know nothing about diabetes. What would you say? What would be the easiest way for you to describe to me what diabetes is?
So that's a good question. So diabetes is all about sugar, isn't it?
Okay.
So why do we need this sugar? Mm-hmm. Sugar is another word is glucose.
Yes.
So glucose is a source of energy. Mm-hmm. That we need that energy to do our day-to-day work, mm-hmm. carry out.
Yep.
We need glucose for our brain
yep.
to function. Mm-hmm. So it's basically like a petrol in the car.
So the glucose is like petrol?
Yeah.
Okay,
that's
fine. Right, okay.
So that's how we go with glucose. So when we eat food, our food is digested in the digestive system.
Okay.
And so it's broken down into various nutrients. So glucose is one of them. So this glucose normally it's absorbed in the bloodstream.
Okay.
It has to go in the blood. So once this is the glucose molecules.
Yep.
So they get absorbed in the bloodstream. And as soon as the glucose enters the bloodstream, we have the insulin.
Okay. Sorry to cut you. Should we see if we can sort of put some visualization into this? So what you're saying is the glucose enters the bloodstream.
That's right.
Like so.
And so exactly how we see.
Okay.
So this is how the glucose enters the bloodstream, and there's after food, and there's a lot of sugar in the blood.
Okay.
As soon as the glucose starts entering, there is insulin. It's a hormone secreted by an organ called pancreas.
Okay.
Immediately it enters the bloodstream. So glucose by itself cannot go to the cells and different parts. It needs insulin.
Right.
So they go together.
Okay.
And this goes to different cells.
Okay.
So normally our cells are very sensitive to insulin.
Right.
They require a little bit of insulin. Immediately open their door and they allow the glucose to come in.
Okay.
So the cells use the glucose for various activities.
Okay.
And liver and other fat tissues, they store this glucose for a good day. When there's no sugar, they break down to
let the body use it as the fuel.
Exactly.
Okay. Yeah,
this is how it happens. As soon as the glucose levels go down, the insulin also goes down.
Right. Okay.
That's normally what happens. But for some reason, this normal mechanism, how the cells are sensitive, something goes wrong.
Okay.
And the cells get resistant, insensitive to insulin.
Okay. And is that built up over time?
Yes.
Okay.
There are various factors. I think we'll come to that.
Okay.
We have our next sessions, various things discussing all about diabetes. Today is only what is diabetes.
Yes, exactly. Yeah.
So because the cells are insensitive or resistant to insulin, the glucose starts building up.
Right.
There's lots of glucose. Insulin there's normal insulin, but takes long time to enter the cells. And so slowly the glucose builds up. Insulin does its best to maintain these levels, bring down the glucose. But at some level, the glucose starts building more and more.
Right.
So the sugar starts building, and at this stage, we can call it as pre-diabetic.
Right.
It goes the normal levels of sugar in the blood will tell when we discuss the results.
Yep.
So when the the glucose goes beyond this normal level, it's called pre-diabetic.
Right.
But it's less than the diabetic level.
So you're not quite diabetic yet,
No.
but you're at high risk of developing
Yes, exactly.
diabetes. Okay.
That's what happens. And so we call pre-diabetic, and it's the best time to target patients, to educate them and bring them back to the normal
level. So I think
level.
that is something we're going to come on to in great depth in the upcoming weeks, aren't we? So what I've understood from what you've just said essentially is over time, glucose is like petrol in a car, and we're the car. But over time, if we're putting too much in, then the insulin will develop a little bit of resistance to the glucose. And the build-up of glucose is over time is then what causes you developing diabetes or high risk of diabetes or pre-diabetes, as you call it. Is that right?
That's perfect.
Right. Okay.
That's what happens.
And there was something you mentioned to me a while ago about a headmistress, the analogy.
Yes.
Yeah. What was that analogy?
I always think in my head that the insulin is like a headmistress.
So the insulin's headmistress.
Yes.
Okay.
If you see the primary school kids, they all come together in the morning at the school assembly ground, and the teacher that sees that all the kids go to their classes respectively, and then she goes back to her class.
Okay.
Only when the school doors are closed or the headmistress is something happened, then all kids are on the ground making a big noise.
So the head teacher is the insulin.
That's right.
Okay. All right. I think that's a really good way of describing what, in a nutshell, essentially what diabetes and high risk of diabetes is.
Yes, that's right. Dr. Nick, when you see a lot of them coming to you,
we do.
Then you send them to me.
Yes.
So how do they come to you? What are the symptoms?
That's a very good question.
Do you diagnose
Very
them?
good question. So there's a few things that we commonly see that we've been seeing. Often the first thing is no symptoms. Often, people will say for years and years, up to a decade, will feel completely fine, and something will happen, and they'll just come in for a routine blood test, and it will be picked up on a routine blood test. So a lot of people will, it's not normally something that they present with, so they won't call us up saying I'm feeling really thirsty, but they'll come in with tiredness or some lethargy, and when you ask your questions, they'll admit to actually, I have been drinking a lot more water recently, which then comes on to the next thing, which is they notice that they're going to the toilet frequently as well, and that's the effect that the sugar has on the body.
So why do they go to the toilet if the sugar is high? What makes them go to
Essentially, they're drinking. It causes what's called an osmotic effect. So you're drinking lots of water, which then causes you to the body not absorbing the water in the correct way, and you're passing it out via your urine. So the
body tries to get rid of the glucose.
Essentially, yeah.
Okay.
So that's two of the main symptoms, and the third one is often just unintentional weight loss, which can be a marker for many other things, but in the context of diabetes, it's probably the three main things that we see in line with no symptoms at all and picked up on a routine blood test. Some people will come in because they have their mum or dad or friend who's newly been diagnosed with diabetes will come in just for a check as well. But that's picked up on a blood test.
Also, do they come with any infections?
Yeah, that's a really good question. So often these are the ones who, have been what we consider fit and healthy for a long time, not come to the doctors in years, and they'll come in with let's say a cut or on their arm, accidentally cut themselves whilst cooking or using something sharp, and the wound just doesn't heal. The healing time takes longer and longer and longer, and it makes you think there might be, and can be the effect of high sugar over a long period of time.
Mm-hmm. We can change our lifestyle, we can change our eating habits, the time we eat, the type of food we eat.
Okay, and this is all something we're going to come on to in a few weeks, isn't it?
Yes. We are going to have a whole class, a whole session on diet.
Smoking is definitely something. Alcohol consumption.
Yes.
And actually one that I don't think is concentrated on enough is sleep and stress.
That's right.
So increased stress levels will increase the insulin resistance.
Exactly.
Yeah.
Our stress level nowadays, we are always on the screen.
Yeah.
We are on the computers, we go home, we are on our phones, we are constantly, and our brain is working. less sleep. So that's one thing we can work on it.
Yeah,
Discipline our sleep.
Yeah.
Also, the weight.
Yes, yeah.
Weight is a person. What you will say about the BMI?
So normally 25 and under is a healthy BMI, but for South Asians, I think the new guidance is 23.
Yes.
And on that note, there was something you mentioned last week about measurements of wastes. What are the sort of things? What are the numbers we should be looking at?
That's very cool. This the fat around the belly is the most crucial, because this can damage important organs like liver and pancreas, and that can hamper the absorption of sugar and insulin resistance and so on. So mainly for a man, the worst circumference should be 94.
94.
Whereas for an Asian man should be 90.
Okay. And that's because South Asians are at higher risk of developing diabetes.
And for a woman, it is 80.
Okay.
Yes. That's the waist circumference. So if you can do a little bit of decreasing, even a centimeter or 2 centimeters, that can take you a long way.
Yeah. I think that was a really good sort of introduction and overview to what type 2 diabetes is. And I think in the upcoming weeks, we're really going to be talking about lifestyle factors, diet, exercise, numbers, targets. Was there anything else that you wanted to add, Maria?
Yes, we can set goals.
Yes,
how
absolutely.
They can set goals, how can they plan their meals. Even if you are very, very busy in your life, you can plan. And planning does help.
Of course.
Otherwise, if you go home and if you're very hungry, we eat whatever is there. So.
And I think just one take-home message would be, and again, we will come on to this, is how well people can do after diagnosis into...
Early diagnosis.
Yeah, into early diagnosis.
Exactly.
Yeah.
Diabetes.
Right. Is everyone scared now about diabetes?
I'm scared of diabetes.
Oh, can you hear me?
Yeah, I can hear you.
I think we might have lost Tal.
Oh,
Are you there,
can you not
Tal?
hear me?
Let me know in the chat if you can hear me. Don't know if we've just
I'm
crashed.
chatting away.
Oh no, okay, you're there.
Yeah, diabetes is really...
I don't know if it's my connection.
Diabetes is quite scary though, isn't it?
The dramatic music.
Is it dramatic? We can change that because we've probably been on it for too long. Let's do...
Oh, sorry, Tal. I don't know if it's...
Let me come out and then I'll come back in. Is that any better? Can you hear me or not?
Might be me. Is it me? I don't know whether you guys can hear okay. Just let us know in the chat. Oh, no. I can, but it's a bit of a delay.
Oh.
I think you're back.
Oh, yeah, the KBS meant the other music.
Say something?
KBS was talking about the music in the other video.
Oh, you can hear?
It's
okay. I don't know, maybe it's me. Just went all funny there.
Can you hear now?
Can you hear, Tal?
Yeah. It's your audio, I think.
Okay, I don't know. Tal's gone quiet, which is very weird. Doesn't happen often. All right, let me just have a quick look in the chat.
Sarah quite often pretends not to hear me, to be honest. Jeez. Oh, what? Okay then, so that is diabetes, and I wonder if we could show another video. So I'm just messaging Sarah, so she can't. I don't know what happened there. Yeah, she's going to leave and come back. Quite frankly, I prefer it when, you know, she's not taking my limelight. So there's some questions. So KBS, you were absolutely correct. South Asians do tend to have much more like to have high cholesterol and diabetic issues. It's and so there's something called the prevalence of diabetes. So the prevalence is quite is higher, and actually the targets for diabetes is more aggressive. So you need to have treat earlier, and actually I think we've had lots of interesting patients who have made some differences in their lifestyle and diet, and a lot of people think, oh well, diabetes is all about, you know, having you know, about taking insulin or taking medication. And actually, what we've found over the years is that it's a lot to do with your diet and exercise. So we've had lots and lots of patients who had really poorly controlled diabetes, and then they try to change their diet and exercise, with not just them but their families as well, and then it's basically improved their diabetes, and sometimes they end up not taking any medications as well. So, oh, we've got Sarah back. Can you hear me now?
Yeah, I mean, this looks a bit different on here, but yeah, I'm here.
But can you hear this thing? So really, so we've got a whole bunch of stuff around diet and exercise and trying to kind of help improve that. And we've got a really interesting video from our diabetics specialist dietitian, and she can, and I'm not sure we've got time to play that today, have we? But or you could do HbA1c video next.
Yeah, I mean, I can't. You're gonna have to do it because I can't. I don't have control anymore.
Oh, it's a shame, isn't it? Let me see if I can.
I can't reply to anything anymore. It's there already, if you just upload it from the video cloud.
Oh, is it? Okay, the diabetes one.
HbA1c. Yeah.
Okay. So.
Yes, you're right. I don't know. Sorry if I went and you were talking about the difference between type 1 and type 2 diabetes. Nothing is. Oh, you find it?
No, I've only got the ones that we've shown.
There should be. It's called HbA1c. Let me just try. I'm going to try and join the other link. 1 second.
All right, while she's off, let me just show you a little video.
They're meant to be sound. I can't hear anything.
Oh, sorry, because people can't hear me. I was talking all the way through that video. Oh, I just told everyone that you've got asthma.
Oh,
But then
great.
it's okay though, because nobody could hear me. But this is as Sarah getting an asthma plan.
Usually that one should have sound on it, but if you play it again, I will talk you through what actually happens in an asthma review. You can have a voiceover, live voiceover. So the nurse will usually call you in. The appointment kind of lasts around like 15 minutes. And then they'll kind of ask you questions about like your triggers, like what, your daytime symptoms, your night symptoms. And there's so many triggers. I know tomorrow we're going to play a video about what sort of things trigger your asthma. There's things like, perfume and like animals, like cats and things. So a lot of it is kind of just talking about how you're getting on with your asthma. Then they do ask you about, they ask you to peak flow. So this device, again, will show you tomorrow what this device is and how you do it, but they make you stand up. And it should go all the way to the top, but as you can see, my asthma is not very good. So, and they might ask you to do this a few times, and then kind of talk through inhaler techniques. So you should be bringing your inhalers to the appointment. You might have different inhalers, but generally there's a blue and a brown one. That's the one that I use anyway. And then the nurse, this was a demonstration inhaler. We didn't have a real one there, but usually you should be using a spacer as well. I think a lot of people forget that. And yeah, they give you an asthma action plan, which has all the details of like, emergency contacts and kind of what to do if you are actually having an asthma attack. So it's really useful. So we get people to like put it on their fridge or somewhere that's really accessible. But yeah, that's the asthma review.
I can't believe I've told everyone about your medical history there. So
Thanks. Great.
it's supposed to be a secret.
Yeah,
Right.
you'll find out a lot more.
It was secretly filmed. Oh, we've got a sprinkler meeting right now.
I've moved that, but I don't think he's seen it. I'll message.
Okay, so we've got half an hour left. So if anyone's got any questions now, so I think if you take an example of diabetes and you take the example of asthma, we'll talk about asthma tomorrow. But somebody with diabetes has to, you need to find diabetic people who are at risk of diabetes. Then, like somebody like Sarah or another manager or somebody in admin would run a search on the computer system to identify people who either have diabetes or at risk of diabetes. Then you kind of have to invite them in. Might be phone calls, might be messages. You might want to bring people into a small events or large events or one-to-one appointments. And then the patients with, say, for example, diabetes, they might come in and see a healthcare assistant for a little checkup and stuff. And they might come in for they might come in for a little checkup with a healthcare assistant. Then they might see a nurse. They might see a clinical pharmacist for their diabetic medication to check what is working, what is not working. The healthcare assistant might do their blood tests for them as well. The results might go to the doctor. They might be unwell, and I might have a diabetic foot check from a physician associate. They might see the dietitian, for example, a specialist dietitian for their diabetes. They might, you're more likely to get problems with, joint problems and other problems. So you might end up seeing a physio. You might want to have some medications, which you need to talk to a clinical pharmacist who pick up from the pharmacy itself. And then you might need to be followed up afterwards, and the admin team help to make sure that happens. So the point is that any of the clinical cases requires like lots of people from lots of different backgrounds to kind of work together. and also with, sometimes like people, like for example, they're at risk of diabetes and they haven't got diabetes yet, but they might do in the future. It's fine to bring in, say 50 people, 100 people together in a little group or smaller groups of about 6 people, and show you can share some basic information, a bit like what we're doing kind of today. So it's something low key, and then and it's nice to talk to other patients as well, and maybe to kind of maybe become friends and stuff. Maybe you've got a different perspective on what diabetes is, and then you might want to. You might be busy, maybe you can't come to practice, and maybe you want to look at like a little YouTube video or something which might help. Maybe you want to contact your practice, maybe whatever it is that works for you. I think to more complicated patients who need to have specialist diabetic nurses, we've got a special clinic for a specialist diabetic nurse. We've got special clinics for people who need to start on insulin, to train them up and to explain how that works, how they should be monitored. To the foot clinic, which there's a specialist diabetic foot clinic, there's a specialist diabetic eye clinic. So all of these different clinics and stuff have, different specialties, like, podiatry, ophthalmology, opticians, pharmacists, clinical pharmacists, hospitals. So all we're trying to kind of get across is the fact that it's not a GP managing diabetes. It's like lots of us, all of us working together. So that's something that's really important to get across in your interviews and in your messages and stuff when you're applying for jobs, and saying that number one is what is kind of your role, which is fine, but also, maybe you're thinking about being midwife and you think, I'm not that interested in what doctors or healthcare assistants do, but actually you need to know what they do because that's how you do your job. So that's why we haven't done anything specifically for midwives or for healthcare assistants or for doctors or for admin. We've kind of joined it all together so that everybody understands a little bit about what everybody else does. That's kind of correct, isn't it, Sarah?
Yeah, definitely. I think it's so important to know that, like, you have to understand what the team does. Like, sometimes it gets a bit confusing because one question we always get, like, especially with our receptionists and our care navigators, they always ask, what is the reason for the appointment? And, people think, oh, is that just to be nosy or what? It's not, because we've got such a big team and everyone sees, different things. And like Tal said, you might have someone who's diabetic and they might see, physician associate, they might see the clinical pharmacist, they might see the doctor, they might see, so they do different, they treat that patient, for different things to do with diabetes. But letting, if you tell the care navigator, for example, they do a lot of signposting and you say, okay, right, I need my, blood pressure checked or I need my medications changed, and they would put you in with the right person to deal with that. And it's not always a GP, which is what a lot of people think. So, people might call up and say, I want to see my GP to, change my medication that's been done at the hospital, but they might not know that, we've got physician associates, you've got clinical pharmacists, you've got pharmacy technicians, you've got people who can do that, a lot more efficiently than the GPs. And obviously, so I think we've definitely, it's good to understand the different roles and how you would work together. It's really, really important. Certificate stuff, I know Tal's put I always love that. You could like point across the bottom and be like, oh look, check the thing across the bottom. But yes, you will have access to a certificate through an app called Motimate. So if you did register through Eventbrite, you'll be getting an email probably later today or tomorrow with a link. So today we've kind of talked about, the GP role, practice manager, healthcare assistant, clinical pharmacist, a bit about diabetes, and that all that information and a lot more will be on the app. So you can go through it in your own time. And I know some of you guys had questions about qualifications. So, you know, all that will be in there packaged up, and then you get to do a quiz as well, so it'll test your knowledge. For KBS, who's interested in cardiology, there's a whole section on cardiology there. So you can actually listen to the podcast with the cardiologist who explains all of that. And yeah, it's all there. So you can do that in your own time. And once you complete that, every section you do, you get a certificate, and you could just, is a PDF document that you could just save and print. But like Tal said, you know, when you're adding it into your, when you're, you know, looking into that, don't just think, oh, I'm just going to put my certificate and say that I've done it. Expect that people are going to ask you questions. That's why we want you to get involved in the project. So what we want you to do is, after listening to us today and tomorrow, we want you to do a social media project. So any part of this kind of the 2 days that you think was interesting, or you want to kind of, we'll give you a clip or something, and you can make that into a short social media post, or you could create like a Instagram post or something like that. I'll shout out to Dr. O'Donovan.
Yay, Dr. Donovan, welcome. I think is amazing. So make sure you like and subscribe to his YouTube channel.
So yeah, I think we will hopefully tomorrow. I think we'll kind of talk a bit more about my asthma.
Oh well, surely you haven't got asthma.
I do. You'll find out. You'll find out tomorrow. You have to find out.
You should have. Yeah, we don't know right now. We don't know. Sarah has got.
We'll find out.
You come back tomorrow. You'll find out.
It's not that interesting.
Apart from the 50 videos you've got about your asthma, and the fact that we've just told everyone. Anything else for today, Sarah? Say, do you want to show any more videos, or should we?
We can. So I know we did a little bit on what is diabetes, but I think what's interesting. I don't know. I don't have access to the. You said, did you find that video on the HbA1c or not?
No. Did you manage to?
I can't do anything on my side anymore. This is what happens when you try something new.
So this is what happens when you got a clinician and a non-clinician. Now, the non-clinician has technical problems, and then the clinician has to try to fix it, and we get nothing. I don't know where it is.
Yeah, I mean, anyway, it is. If you can find, you could do. What video do you have access to? Do you have access to anything?
Tomorrow will be way better, guys, because I've only got. Is this? Oh, I think you're right. Oh, I stand corrected. All right, guys. Here goes. You know what? I've just proved that clinicians can do stuff. So there you
let's
go.
see. Just we'll see if that.
Diabetes is the HbA1c.
Okay.
Are you able to tell us what the HbA1c is?
That's right.
Yeah.
HbA1c is glycated hemoglobin. And this hemoglobin, we check the sugar carried by the red cells. The good thing about this test is it's very simple. Patient do not have to fast. It can be done anytime. It can be done at the GP surgeries, where we send the blood to the lab for testing, in the hospitals, and the results come quite quick.
So it's a little bit more convenient to test for HbA1c, because people would often come in forgetting that they had to fast, or being left without food for long periods of time.
And you don't know whether sometimes patients say they are fasting,
yes,
but you don't know how long they fasted.
Exactly.
When the results come, sometimes they may say, oh, I just fasted, I had my meal at 3 a.m. in the morning, especially the shift duties, so on.
So what is this HbA1c that we talk about?
Well, I brought a small model for you to show. So this is a red cell, and the red cell contains a protein called hemoglobin, which carries oxygen. So the sugar molecules get attached to this protein, and it's called glycated hemoglobin. So this is the normal red cells, and these are the sugar molecules which are attached. But in a case of pre-diabetic or diabetic, see the number of molecules which are attached. So what we do is we measure the amount of these sugar molecules which are attached to these red cells, and that gives us the amount of sugar it carried. Normally these red cells is active for 3 months, or every 3 months we get a new one. So we measure the average number of molecules carried by the cells in the last 3 months. Hence, we do it every 3 months, isn't it?
I think so. So what I've understood from what you've said, essentially, the HbA1c is an average over the last 2 to 3 months of how much glucose has attached to our red blood cells. And if there's a higher amount of glucose in our system, then our HbA1c count will be higher.
Definitely.
Is that right? As displayed by this?
That's right. You can see how many molecules are in this and how many are there. The white ones are the sugar molecules. That's right. So that's all about numbers, isn't it?
Yeah. I mean, the numbers are really important, especially for people who we screen as high risk, or people who have had diabetes for a long period of time. Keeping a track of their HbA1c is crucial.
All right, that's right. And what about these numbers? Like when the results come, how do you talk about this?
So how do we talk about HbA1c?
Yes,
this is a conversation we probably have daily, and we've got this
traffic lights.
Yeah, we've got the beautiful traffic light system.
Yeah.
So anything from, less than 41, so 31 to 41 is good. Yep. Okay, yeah, absolutely. So anything from 31 to 41 we consider good, and we're not really worried about that. Now, if we go from 42 to 47, that's when we identify you as having high risk of diabetes.
Okay.
So these are the people who we speak to and say, look, you don't have diabetes, but you're at high risk of developing diabetes. This is commonly, or used to be called, things like pre-diabetic or borderline diabetic, as a lot of people know it, but we now call it at high risk of developing diabetes. And then 48 or above is what we call, two measurements of 48 or above will then give you a diagnosis of type 2 diabetes. Or if you have symptoms of type 2 diabetes, like we discussed last week, which is excessive thirst, excessive urination, or weight loss or lethargy, and one reading of 48 or above, we then say you have type 2 diabetes.
Okay, that's interesting.
Yeah.
But you can go up and down, isn't it?
Yes, absolutely.
So from 48 you can go up to 31 as well.
Well, we had someone last week, didn't we, in our group session, who had got, I think his HbA1c was 56 at one point,
that's
and
right.
just through diet and lifestyle and your wonderful support,
I know, he came to me.
Yeah, he brought it down into sort of late 30s. So he'd completely,
yes. He was very
wonders.
Happy about it.
He was very happy. He'd worked wonders. Yeah, so that's how we diagnose diabetes, normally through blood tests. So 2 or more readings of 48.
And why do you need this 2 or more if person has no symptoms and you do this in a couple of weeks, you repeat it? Why do you repeat this?
It's a good question. So if someone comes in, they've had a blood test, they've got no symptoms, and let's say for argument's sake their number is 50, and we phone them and we ask them a few questions. Have you been feeling like this, or the symptoms, and they're not symptomatic, then what we will do is repeat it a couple of weeks later, and that's number one. It's just for confirmation, really, and to make sure there wasn't an error with the lab.
All right.
These things can happen, so it's more so for confirmation. And if the second one comes back at 48 or above, then they have a diagnosis of type 2 diabetes.
And then what happens with these numbers? When they come and see doctors or other healthcare professionals, do you set any targets for these patients?
Yeah, so that's a really good question. So targets are generally given on an individual basis, as opposed to a one fit for all kind of scenario. What do you do when you, because I've seen so many patients that have come in with hitting their targets that you've spoken to. What kind of targets do you give the people you see?
You know, if they are within their best target should be, especially if somebody is newly diagnosed
Yes.
and all, we set a target. Normally the health professionals, like doctors, clinicians, they set a target between 48 to 58.
Yes.
Within that, to do their best. Initially, they may want to try exercise, diet, if they're on just starting diabetes or 48 and just above 48. So they would sometimes like to do all these lifestyle changes, and they want to see that whether they're in their target or less than that, which is a good sign. So, but basically in first 6 years of newly diagnosed diabetic should aim to be less than 53 or less.
Yes.
That's it, isn't it?
And I think time and time again we've seen how countless number of people who have numbers wise been around the 50s, mid 50s, just like the person we spoke about earlier, who have been able to just bring it back into remission just through diet and lifestyle and mindset.
And I think these numbers, when they see these numbers, it gives them a good incentive.
Yes.
It's like a lottery number.
Yeah.
If they have achieved that number, getting back into the lesser part, so they feel very happy. How the other day the patient was so thrilled that he got into it. He said, I can celebrate now, I've come out without medicine.
Yeah. So I think it gives people a motivation, you know, with understanding exactly what diabetes is and the potential complications of long-term uncontrolled diabetes. It gives a lot of people motivation and an incentive to really turn it around.
Yeah, that's very right. And I think people in insulin, like we refer them to the hospital, the secondary care or diabetic specialist, and they set a different target for them, isn't it?
Yeah, so like again, targets are set on more so on an individual basis for anyone who's newly diagnosed or had a diagnosis within the last 5 to 7 years or so. We always aim for a number less than 53 and as close to 48 or less if possible.
So this HbA1c, can we do this to everyone or it's only for some patients?
Yeah, no, so HbA1c generally is the most commonly used test for diabetes. The only exclusions are we don't use a HbA1c in children. We do not use it in pregnant women like we discussed earlier. We do a slightly different test to test for any signs of diabetes. We don't do it 2 months postpartum. So if you've given birth, up to 2 months after giving birth, the HbA1c will not be a reliable method. We technically, according to the textbook, shouldn't use it in type 1 diabetics as well. But apart from that, everyone else will get a reliable reading of HbA1c. Just on that note, some people with hemoglobinopathies, which are alpha thalassemia, beta thalassemia traits, will often not have a reliable HbA1c results. And there's other things other tests that we can do to get.
All right.
Yeah.
No, that makes sense.
Yeah.
And so once this HbA1c, how often we should check? But that's many times. We have the pre-diabetic, we have the diabetic. How often we should be checking?
Yeah, good question. So for people with an established diagnosis of diabetes, according to the absolute gold standards, we should be checking it every 3 to 4 months. Often we do it more on an individual basis as well. So if someone has come and really made a good turnaround to their lifestyle, and said, you know, I've been implemented exercise, implemented dietary changes and had all the right support, we can measure it sometimes sooner. There's no point measuring it in less than 3 months' time just because of how you explained red blood cells.
That's right.
And the HbA1c, it has to be at least 3 months apart. So with people with an established diagnosis of diabetes, up to 3 or 4 times a year. In many cases, I appreciate this isn't always done, and people of high risk of diabetes normally annually.
Yes, and this pre-diabetic, who we give them a test annually. Suppose they come with some symptoms like polyuria, going to the toilet, increased thirst. Do we check them before?
Yeah. So again, I was on the other side of the coin. So if they come and they have high risk of diabetes and now developing symptoms, absolutely, I think that would be more than justified to test them.
because many a times I've seen the newly diagnosed diabetic, and
Yeah.
I had seen that, oh, these people had their HbA1c 3 or 4 months back, and they were pre-diabetic then,
Yes,
and
yeah.
now they have become diabetic
And they've got symptoms.
within couple of months. And what do you think went wrong here?
I think more so it's just increase of insulin resistance over time, and like we discussed, lots of factors that can control or regulate our sugar levels, from food to exercise to stress to smoking. A lot of different things that may have happened in those couple of months from seeing someone.
And also that advice and initial, even when they are diagnosed with pre-diabetic, the initial, like we refer them to experts for lifestyle changes,
Absolutely,
dietitian,
yeah.
that's to be taken seriously, isn't it?
Oh yeah,
So that we
amount
can
of time.
come back to this and give a
Yeah.
thumbs up to 31.
Yeah.
It's all about numbers.
Yes, yeah. So today's session is all about numbers, but the amount of times that even people you must see who have gone from 48 or above to back down to normal figures, just with the right support, the right
Yes.
guidance, and I think a lot of it is about education.
It's
So people
very
just
much,
just
I agree with you.
understanding what is diabetes and how do we control it.
That's right. It's all about knowing and knowledge. Other than the HbA1c and blood sugar, what are the tests we do for this diabetes?
Yeah, so if someone has an established diagnosis of diabetes, often annually we should be checking their cholesterol, their lipids, and we want their bad cholesterol to be as low as possible. So we're quite aggressive with our cholesterol targets for patients or people with diabetes. So we do a full lipid profile, so testing all the different types of cholesterol with a main target on the bad cholesterol, as we call it. And also we check the kidney function as well. That's part of your diabetic check.
Why do we check this kidney function? I think a kidney is like a sieve, isn't it?
It is, yeah.
Yes,
Yeah.
and it filters all the good things put back in the blood and throws the things what are not necessary as in the urine.
Yeah, exactly.
What happens in diabetes and why we are worried about this?
Yeah, so often, again, with long-term poorly controlled diabetes, it can have an effect on your kidneys where the kidneys stop functioning as well as they once did. They will start to decline in function. They become leaky. You're leaking protein, which is another test we do in diabetes. We always do a urine sample to have a look at protein in the urine and how much protein we're excreting in the urine as well. And just leading on from that as well, eye checks are crucial. So
that eye check you get once in a year.
I believe so, yes.
And if there is something, if some changes or complication has taken place, then they refer to the secondary, that's the hospital, isn't it?
Yeah.
And then they may be called every 3 months or so for follow-ups.
Yeah, it all depends on the individual basis, but bringing it right back to the core is that's over a long period of time, generally, of poorly controlled diabetes. So if we've spotted it, or if we've spotted someone who's at high risk of it, I think we can really make active efforts as a whole community, as a whole team, including the person and patient, to minimize any complications and keeping your sugars in really good control.
That's right. Thank you so much. And also the thing is that the follow-up coming for these results should be really the patient, we have to emphasize that they come regularly for their follow-up. That is more important, so that if they have deteriorated, we can take proper actions, increase their do the medication review, and improve their sugar levels and prevent complications.
It's all about teamwork. So from the person to us to everyone else involved, it's all about working together to try and get on top of this and control it as well as possible.
And education is the key.
I think so.
The more patient knows about their diabetes, they're their own doctors.
Absolutely. Diabetes is...
What a lovely video, isn't it?
Oh, I miss Maria.
She's only gone on holiday.
I know. Maria's like a mum in the practice.
No need for that.
Oh, all right.
So I hope, thank you so much, guys, for bearing with us with the technical stuff, and we've never really done it quite like this before. It'd be good to get feedback and stuff actually of how it went and stuff. So, but yeah, I just want to put up a little message from Dr. O'Donovan again. He's a GP and does a lot of social media stuff. But he wishes they had something like this when applying for medical school. So, and I think having this around is fine, but actually it's what you do with it. It's your reflections and stuff. World to Robux. I know you've mentioned a few times about your specific issue around being a doctor from abroad. You could just private message us and we'll get back to you. We'll see what we can do to help, and also we'll bring in somebody who's done that as well. KBS was very informative. Thank you, KBS. So hope you've woken up now. After, hope you set your alarm for 9:59 tomorrow. Nothing too early. Tomorrow, Sarah, what we do?
Tomorrow we'll cover a bit more about asthma and about physiotherapists. So especially working within a PCN, so we'll explain them what that is tomorrow. Bit more about GPs, and yeah, won't give too much away. So yeah, that's what to kind of expect tomorrow. So a few different roles, but we'll keep it sort of similar to today. So learning about different roles and then going into some of the clinical topics.
Perfect. Okay then. Well, thank you guys. Enjoy 12 o'clock. It's time for lunch.
Yeah.
Healthy lunch, isn't that right?
Yes. We're going to ask you tomorrow. You tomorrow, okay? What you had for lunch and for breakfast, so make sure it's healthy.
We've got some AI stuff, haven't we, to detect if anyone's not quite being honest.
Exactly. We should get you to take pictures and send it to us.
Yeah, that's what you do. All right, guys, take care. Enjoy the rest of your day.
Bye.
Bye.